Bismillahirrahmanirrahim. Dear students, today we are going to discuss the anti-inflammatory drugs. In part 1, we will discuss the non-steroidal anti-inflammatory drugs, while the second part of this lecture we will be discussing the glucocorticoids. So, what are anti-inflammatory drugs? So, in this lecture, you will be able to identify the classes of non-steroidal anti-inflammatory drugs. You'll be able to recognize the agents in the classes and their indications, the differences between NSAIDs and other analgesics, mechanism of action, therapeutic indication, adverse effect, and contraindication of NSAIDs. Anti-inflammatory drugs. The main anti-inflammatory drugs are glucocorticoids and non-steroidal anti-inflammatory drugs. So in this lecture, we will be discussing the non-steroidal anti-inflammatory drugs. NSAID have three major effects: anti-inflammatory, analgesic, and antipyretic effect. So all these effects, these are the main effects, but some of them have more antipyretic effect or analgesic effect, while some of them have more anti-inflammatory effect and less antipyretic effect. And that is because of the activation of different inhibition or activation of different enzymes. So in this lecture, we will be differentiating different NSAIDs which are inhibiting different types of enzymes. The main features of NSAIDs include they are also called non-narcotic and non-opioids. Remember, we have discussed the opioid analgesics. They have strong analgesic activity, but they have the liability for abuse. So this is the advantage of this NSAIDs, that they don't have any abuse liability. They do not cross the CNS, they do not produce physical dependence, unlike opioids. However, they have less analgesic activity as compared to opioids. Analgesic, antipyretic, and anti-inflammatory actions, all they have these three kinds of action. Pharmacological effect of NSAIDs. So pharmacologically, we can use this NSAID broadly for analgesic activity. As we have discussed, it has analgesic activity, although it is weaker than that of opioids. So it can be used for mild pain relief. Refer to the relief of pain, for example, headache. Produce a mild degree of analgesia, which is much less than the analgesia produced by the opioids analgesics, such as morphine, that we have already discussed in the opioids lecture. Anti-inflammatory action. This is the advantage of this. These drugs are used to treat inflammatory diseases such as rheumatoid arthritis, that joint pain, that is because of the accumulation of uric acid. So they are very much effective as anti-inflammatory drugs. Antipyretics, it can reduce the fever, lower the elevated body temperature by their action on the hypothalamus. And antiplatelet, you might have remembered the antiplatelet effect of the aspirin. So aspirin in this class can have anti-inflammatory effect by inhibiting the platelet aggregation, but it can lead to prolonged bleeding time, have other an anticoagulant effect as well. So the main pharmacological actions of this class as a whole: analgesics, anti-inflammatory, antipyretic, and anti-inflammatory. Then we will discuss the different types in these NSAIDs. Some have more anti-inflammatory action, some have more antipyretic action, and that depends on the inhibition of different cyclooxygenase enzymes. Now the mechanism of action of NSAIDs. Basically, NSAIDs inhibit the cyclooxygenase enzyme, and this cyclooxygenase enzyme converts the arachidonic acid into prostaglandin, thromboxane, and prostaglandins, which are the inflammatory mediators. Where this arachidonic acid come from? Whenever there is an inflammation or injury that happens that disturbs the cell membrane, so cell membrane causes the release of the stimulus, causes the release of phospholipids from the cell membrane, and phospholipids is converted to arachidonic acid with the help of phospholipase A2 enzyme. Now, arachidonic acid has two pathways. One is called lipoxygenase pathway, another is called cyclooxygenase pathway. So NSAIDs work here. It blocks the cyclooxygenase pathway and inhibiting these inflammatory mediators, and that lead to decrease in the inflammation. However, when you block the cyclooxygenase enzymes, the balance or the equilibrium shift toward the lipoxygenase pathway and more leukotrienes are formed, and that can lead to the bronchial constrictions because of the leukotrienes production, and this will lead to bronchospasm and congestion. So that could be the side effects of these drugs. Now we will discuss the different types of cyclooxygenase enzyme, that why certain drugs have more antipyretic action and some have more anti-inflammatory action. If you can see this lipoxygenase pathway where arachidonic acid is converted to a different prostaglandin. So cyclooxygenase has two types, COX-1 and COX-2. COX-1 is a physiological regulator, and normally it causes the production of PGE2, PGI2, and thromboxane. This thromboxane is important for the platelet function that you might have seen in the antiplatelet effect, that aspirin in low doses inhibit this cyclooxygenase enzyme, and that leads to the decreased aggregation of platelets. And that is because of this inhibition of thromboxane A2, which is responsible for the platelet activation. So one of the anticoagulant effect of this aspirin is because of the inhibition of cyclooxygenase 1 enzyme. While this COX-2 inflammatory response by nimbly expressed cyclooxygenase 2. So COX-2 is mainly responsible for the production of mediators that can cause inflammation, pain, and fever. So the anti-inflammatory, anti-analgesic, and antipyretic effect of these drugs is because of the inhibition of COX-2 enzyme. So it's better to have a more selective COX-2 enzyme in order to inhibit the function of this, in order to preserve the function of COX-1 enzyme, because COX-1, it has two functions basically. It can also causes the GIT protection by producing PGE2. So if you are inhibiting COX-1, that means you are inhibiting the GIT production, and it can lead to ulcer. PGI2 also play an important role in the GIT protection, and here you are decreasing the platelet activation, so that would lead to bleeding. So for anticoagulant effect, this is beneficial, but in normal individual it can lead to thrombosis or heart problems. And these heart problems come when you selectively blocks the COX-2 enzyme, because when you selectively blocks the COX-2 enzyme, you are inhibiting the ulcer formation, but that can lead to platelet aggregation by producing more thromboxane. And because of this selective COX-2 inhibitors have to be used with caution with those patients who have cardiovascular problems. A third COX-3 enzyme is also have been isolated or discovered, and that is mainly present in the brain, and COX-3 has more antipyretic effect. So we will discuss that in the later slide. Now, mechanism of action of NSAID, as we have discussed in the previous slide, what it do, it decreases it inhibits the cyclooxygenase enzyme, and thus decreasing the formation of pain mediators both in the peripheral and central region. and then it depends on the different types of cyclooxygenase enzyme. Non-selective NSAID will inhibit all the enzyme COX-1, 2, and 3 and can have all the analgesic, antipyretic, and anti-inflammatory effect. Selective will depend, if anyone is more selective to COX-2, it will have more anti-inflammatory effect, but that will not have anticoagulant effect or analgesic, antipyretic effect, because antipyretic is mostly associated with the inhibition of COX-3 enzyme. So the anti-inflammatory properties reduce prostaglandin synthesis at the site of injury in the peripheral region. So cyclooxygenase, as we have discussed, it has three isoform. COX-1 is constituted, acts in physiological condition, and it is important for the GIT protection and platelet aggregation. So if you are stopping this COX-1 enzyme, you are stopping the GIT protection, which will lead to ulcer, and it will inhibit the platelet aggregation, which will lead to bleeding. COX-2 is induced in inflammatory cells by pathological stimulus. Whenever there is pathological stimulus, then this COX-2 is induced, and it can cause these in the formation of inflammatory mediators. While COX-3 is mainly in the brain, and it has more antipyretic effect. It can decrease the temperature of the body or fever. Inhibition of COX-2 is thought to be due to inflammatory and probably most analgesic and antipyretic effect of NSAID. So COX-2 inhibition of COX-1 is responsible for the GIT toxicity because you are decreasing the production of PGE2 and I2, which are responsible for GIT protection. So NSAIDs, non-selective, can block both COX-1 and COX-2. Selective, whenever you see this COX-ZIP, that means there are selective COX-2 inhibitor. Preferential, some drugs have more preference toward COX-2 as compared to COX-1, and COX-3 inhibitor have more antipyretic and analgesic effect, but it has less anti-inflammatory effect at the peripheral region. So the drugs which are more selective towards COX-3, they will have more antipyretic effect. Drugs which are more selective towards COX-2, they will have more anti-inflammatory effect, and non-selective have all these effects. Now we will discuss the drugs which are more selective towards COX-1, COX-2, or COX-3, and that will differentiate their function between the anti-inflammatory effect and the antipyretic effect. So the original NSAID, aspirin, is the main prototype of this. Ibuprofen, naproxenes, indomethacines, pyridoxine, paracetamol appear to be non-selective for COX-1 and COX-2. However, there are some preferences. Some are have more preference toward COX-2, while some have more toward COX-3 or non-selective. So aspirin and paracetamol, most commonly used drug. Aspirin is normally used as anti-inflammatory drugs, while paracetamol is used mainly as an antipyretic effect. And why? That is because of the inhibition of, it is more selective towards COX-3 enzyme. And now development of selective COX-2 inhibitors, Cyclooxygenase, Etocoxib, Paracoxib, have similar efficacy to that of the non-selective inhibitor, but the GIT side effects are decreased by 50% and less renal problems. So these COX-2 are morely selective towards these COX-ZIP are more selective towards the COX-2 enzyme. That's why it has more anti-inflammatory action and it has less side effects as compared to the COX-2 with regard to GIT. However, it can lead to cardiovascular problems in patients who have abnormal coagulation, because you are increasing the concentration of thromboxane, which will lead to the aggregation of platelets. So current advice restrict the use of coxib for patients whom treatment with the other NSAID can cause serious problems. So if a patient has serious GIT problems, then COX-2 are more beneficial for them. But if there is a risk of cardiovascular problem within the patients, then COX-2 should not be used. COX-2 inhibitors, whenever you see COX-7s, that means they are selectively inhibiting the COX-2. Preferential COX-2 inhibitor, meloxicam, nimesulides, these have more preference toward COX-2 enzyme as compared to COX-1 enzyme. Sheer toxicity of all NSAIDs. It can lead to GIT mucosal damage or ulcer because of the inhibition of COX-1s that we have already discussed, and bleeding. It can lead to bleeding because of the inhibition of COX-1 again, because COX-1 inhibit the thromboxane synthesis and the prostaglandins, which are responsible for the GIT protection. So these two side effects are more common with non-selective NSAID, non-selective COX inhibitors. However, COX-2 inhibitor, selective COX-2 inhibitor will not have these two side effects. A limitation of the renal blood flow, it's also one of the problem with the NSAIDs, that they can cause the renal damage or the kidney damage after chronic use, and that is because of the for decreasing the formation of PGE2 and PGI2, which normally maintain the normal glomerular filtration rate. So it's also one of the side effects of this. However, the problem with the COX-2 inhibitor is that it has less GIT effect and less bleeding. However, COX-2 inhibitor that can have effect on the cardiovascular system. So if you block only the COX-2, more it will shift towards the COX-1, and it will increase more thromboxane production, and that can lead to myocardial infarction. It can also causes the endothelial function of the blood cell, so that could lead to hypertension. It can delay the prolongation of labor by decreasing the prostaglandin synthesis, which are responsible for the uterine contraction. Asthma and anaphylactic shock because of the production of more leukotrienes, because when you stop the cyclooxygenase pathway, the balance shift towards the other pathway, that is the leukotrienes production. So more leukotrienes production can lead to asthma and anaphylactic shock, and rashes. It's more common. Commonly, some patients are allergic to salicylates, and that leads to rashes and these side effects. Generally, there are no really significant differences in the main pharmacological actions between the currently used NSAIDs. However, the exception is the paracetamol, which is generally believed to have little or no anti-inflammatory action. You might have noted that we are going at these fifodol or paracetamol for fever, right? For its antipyretic effect, but not for anti-inflammatory effect, and that is because of its more selectivity towards COX-3, and COX-3 are believed to be present in the CNS and responsible for the decrease in fever or temperature of the body. So that is the only exception here, which is generally believed to have no allergen. The paracetamol, also called acetaminophen in the USA, is a weak COX-1 and COX-2 inhibitor in the peripheries and possesses no anti-inflammatory effect at the peripheral level. It mainly inhibits the COX-3 enzymes, which is mainly present in the CNS and mainly responsible for controlling the body temperature. So acetaminophen has only analgesic and antipyretic properties by inhibiting prostaglandin synthesis in the CNS. And this you can see here that the differences between the general NSAID only if it is non-selective, it can have all anti-inflammatory, analgesic, and antipyretic activity. However, acetaminophen has a strong antipyretic and analgesic effect, but it doesn't have or have very weak anti-inflammatory action. So acetyl salicylic acid, the main prototype of this class, aspirin, it is metabolized to salicylic acid, which is irreversible inhibitor of cyclooxygenase enzyme. That's why it has long duration of action. It is the only one in this class which is irreversible inhibitor of COX. The other are reversibles. It is indicated as analgesic, antipyretic, and anti-inflammatory actions. Antiplatelet action can be achieved through lower doses by inhibition of COX-1 enzyme only, which suppress the platelet aggregation by inhibition of the thromboxane synthesis. Side effects, gastrointestinal symptom, very common. That is because of the inhibition of COX-1 enzyme. CNS toxicity, it can have this salicylism or CNS toxicity. Allergic reactions, urticaria, this is urticaria, angioneurotic edema, aspirin asthma because of the production of leukotrienes, and can lead to anaphylactic shock. Renal damage that we have discussed, hematological effect because of the inhibition of COX-1 enzyme. Because low doses aspirin decreases excretion of uric acid, it should not be used in patients with gout because it will lead to hyperuricemia, increased amount of uric acid in the blood, and that leads to the gout, because in gout we have more accumulation of uric acid in the joints that lead to that joint pain. NSAIDs are considered to be as category C drug in the first and second trimester. In the third trimester, it is considered to be as category D drug. But it should not be used in the pregnancy. It can also be excreted in the lactating mother, so this should not be used for mothers who are feeding their babies. Other unwanted effect of the aspirin. In addition to the general unwanted effect of aspirin may cause salicylism, which occur with repeated ingested doses of fairly large amount of salicylate, that is more than 5 grams per day. So it can be produced in abnormally high amount of drugs, could be accidental or intentional, depends on the use. So what this is salicylism? It's a syndrome consisting of tinnitus, a high-pitched buzzing noise in the ears, vertigo, decreased hearing, and sometimes also cause nausea and vomiting. How we can reduce the concentration of acetylic salicylate in the body? So remember we have discussed in the toxicology how we can decrease the drugs which are already absorbed into the blood. So if it is acidic drug, we have to make the urine alkaline so that it can remain in the charged form or in the polar form within the in the kidney and can be excreted out. And for basic drug, it should be vice versa. So aspirin is acetyl salicylic acid, and sodium bicarbonate, it makes the urine alkaline. That's why it causes the excretion of this acetyl salicylic acid or aspirin in case of poisoning. Aspirin is epidemiologically linked to encephalitis or Reye syndrome, which can damage the liver and the brain if given to children with viral infection. So normally aspirin should not be given to patients or to children, especially for fever. They should be given paracetamol. in order to inhibit this Reye's syndrome, and it can have hepatic damage. It's one of the most common side effects with large doses of aspirin. Celecoxib and roxacoxib both are selective inhibitor of COX-2. However, rofecoxib, it has been removed from the market due to its cardiovascular side effects. So nowadays, the celecoxib is used as a selective COX-2 inhibitor for the treatment of arthritis. So it is a more effective drug for the treatment of the arthritis, which is because of the inflammation and because of its anti-inflammatory effect. The choice of NSAIDs depends on the pharmacokinetic behavior and adverse effects. So it has to look into the we have to look into the cost or the benefit versus risk ratio. If the risk is more than the benefits, then we don't have to use the drugs which have more risk as compared to the benefits. So COX-2 have more risk in the patient who have cardiovascular problems. So for that purpose, they should not be used in patients who have cardiovascular problems. So the risk factor for NSAID GIT toxicity, mostly the patient who have older age or was using steroids, who have rheumatoid arthritis, history of peptic ulcer or high dose of NSAIDs. These are the risk of GIT toxicity for those patients. So to summarize, we have discussed NSAIDs in general, and then the main mechanism of NSAID is the inhibition of cyclooxygenase enzyme, and their anti-inflammatory, antipyretic effect depends on the selective inhibition of COX-1 or COX-3 or COX-2. So COX-2 have more anti-inflammatory actions. COX-3, it has more antipyretic action, while COX-1 is a physiological induced by a physiological response, and it can lead to the production of prostaglandins, which are responsible for the GIT protection and also platelet aggregation. So if you're stopping this COX-1, it can lead to ulcer and it can lead to bleeding. The effects, all of them have analgesic, anti-inflammatory, antipyretic, and anti-platelet action. Anti-platelet action is more selective towards aspirin because at low doses it can have this COX-1 inhibitory effect. Toxicity, GIT, mucosal damage, bleeding, limitation of renal blood flow, delay labor, asthma, and anaphylactic shock. That's all about the non-steroidal anti-inflammatory drugs. If you have any question, you can email me, or you can call on my office extension at 45498, or you can ask me on the Blackboard discussion section. Thank you.